Dr. John Bennett broadcasting from Miami Beach. We have another Yuha Hernizniemi Grand Rounds from China. And I'd like to introduce Yuha right away. Okay, Yuha, it's all yours.
Okay. Hello, everybody. Good evening from here. Good morning. Good day.
Good morning from Morocco.
So today we have Professor Atul Coyle. He will speak on sellar and suprasellar tumors. This is very interesting area and certainly interesting for all neurosurgeons. So Professor Atul Coyle, to be repeated once more, he's coming from Mumbai, India. He's the chairman of King Edward's Hospital and certainly is one of the most important neurosurgeons of these times in the world. This is certain. So how to become a good neurosurgeon? I never met a person who wanted to become a bad neurosurgeon, but there are some advices. Train hard, learn very well anatomy, like I mentioned. To learn anatomy, anatomy needs more than lifetime, so we are never ready. So you have to follow the way Professor Atul Coyle is doing. This is good role model for the younger neurosurgeon and also for older, like for me. So I have learned very much from Atul Coyle, Professor Atul Coyle. He's passionate lecturer and his lectures are wonderful. So you will see and listen one example in the following on these tumors. Neurosurgery has three parts: operative skills, and these are growing only by hard training and increasing your experience. And there is a research, clinical and basic, and then teaching. And like John Bennett has given the name, Atul is the king of webinars. He's teaching all the world now, and his lectures are very convincing, so you will learn a lot when he's lecturing. So how to improve all the time? You have to analyze your experience, and this makes you 5 or 10 times better surgeon. You should publish your experience. This is very important, to share the experience, good and bad experience. You should not believe everything what's going on in neurosurgery. You have to be critical and also criticize old ways of treatment and to try improve everything. Thinking and observing what you are doing is extremely important, and you have to learn from others. You have to have open mind and young open mind to learn all the time something new and all the time changing your ways of thinking and your surgeries and treatment of patients. Some years ago, 2014, World Neurosurgery selected 69 most important neurosurgeons in the last 100 years. And besides Cushing, Dandy, Yasakil, and many others, we can see here is Atul Coyle from India. He certainly deserves his place inside of this cream of the cream. He has published profusely, more than 800 publications, and like we discussed once here in webinar, he had very big difficulties to publish many papers because they were not accepted. So there has been long and rocky road to publish such a big number of publications. But he has published profusely and analyzed his cases very well, and this is very important, and this is very good teaching for all the world. So he's doing a lot of operations, 1,500 personal operations a year, To do that, you have to be excellent neurosurgeon, but also you have to organize your department very well. You have to have good supporting team around you to help in surgeries and other tasks of chairmanship and professorship, and you need a supporting the society around you and big number of patients, of course, to have that kind of big bunch of surgeries. So this is one of the important principles. The young generation is always getting better than the young ones, older ones. So we should train our best young people. My teacher, late Professor Drake, said that if we don't find that kind of people, then we wait. One day they will come who will become better than we. And this is very important principle to select the best trainees. So I give now the word to Professor Atul Coyle. He will speak on sellar and suprasellar tumors. Please, Atul, go ahead.
Thank you, Juha, for that introduction and for that honor to be able to present in this very important webinar. There is no question that Juha is one of the most celebrated and one of the most loved neurosurgeons of the world. And to be able to speak in his webinar is my great and singular honor. And I have selected today, and also my dear friend Bin, who is one of the very, very celebrated vascular surgeons and one of the stars of modern neurosurgery. And I am indeed happy that Bin is going to translate my lecture into Chinese. And of course, Takashi is sitting here and one of the very emerging stars in brain tumor surgery. So my topic today is, which I have selected, is pituitary tumors. And I will take you to the world of pituitary tumors. And I will take you to my world of pituitary tumors. Pituitary tumors are very important part of neurosurgical training. And I know many of the people in the audience are young students of neurosurgery, and I am sure they will like to know my thoughts on this subject. So this is the pituitary gland. Pituitary gland has a very unique location. It is neither intracranial nor extracranial. It has its own discrete cella or own discrete house, which is neither inside the brain or outside the brain. Now, this special location of the pituitary gland, from here it regulates the whole body, master regulator or master organ. So this is the pituitary gland. And if you see, the pituitary gland has got very fantastic relationships. One is with the cavernous sinus. You see, the cavernous sinus is located on both sides of the pituitary gland. And the other very important relationship that you will see is the sphenoid air sinus. So the sphenoid air sinus is huge, and it is related directly to the cavernous sinus and to the pituitary gland. So this relationship of the pituitary gland with paranasal sinuses and nasopharynx is very important. You see, when we breathe in, when we breathe air, it may be cold or it may be very cold, but when it goes in the nose through the turbinate, it rolls, the air rolls. The mucosa is the most vascular mucosa structure of the whole body. Mucosa is the most vascular structure of the whole body. So when we breathe in, the air rolls in the nasal turbinates and that these are called the air conditioners of the body. And if we drink hot water or cold water, it rolls in the oral mucosa, in the nasopharynx. And when the food goes in the esophagus, it is normal temperature. Similarly, when the air goes in the trachea, it is not cold or hot. It is normal temperature. So these are the air conditioners of the body. And these air conditioners, this mucosa gives information to the cavernous sinus. And cavernous sinus also gets information about the body temperature through carotid artery. Carotid artery has also twisting and turning inside the cavernous sinus. So this information of the body goes in the cavernous sinus and directly into the pituitary, and carotid artery gets information from the body, and this information both is relayed about the external situation to the pituitary gland, and then the pituitary gland regulates the whole body. So these are the speculations that the location of the pituitary gland has a special function. It is not arbitrary. Like the human testis is located outside the body. So it has special function for temperature regulation and for whatever. Thyroid gland is located under the skin. So it has got a special, the locations are not made just like that because it has unique function. Similarly, pituitary gland is located in a very fantastic situation where it is able to carry out its function. So this is the sella, and these are located right by the side of the anterior clinoid process and internal carotid artery. So internal carotid artery is located in very close proximity in the cavernous sinus and in the supraclinoid area as well. So it is this unique house of the, so if you ask me where is the address of pituitary, so this is the house of pituitary. And the neighbors are very high profile neighbors of the pituitary gland. So this is the diaphragm celli. You see the diaphragm celli? This is a thick layer of dura, And this is the pituitary stalk. You see there is a hole in the diaphragm celli. And this diaphragm celli hole is in the normal situation. And I will now show you in a tumor situation what happens to this hole. So there is a thick dura of the diaphragm celli. And if you see from the nose, there is a very prominent layer of mucosa which covers the sella, then there is bone, then there is dura. So these are very elegant and very profound membranes that surround the pituitary gland. And these membranes have to be studied, they have to be understood, and they have to be accordingly valued during the surgery. You see, these are, as far as the mucosa is concerned, it is the most vascular structure. You touch it and it bleeds like foam or like vapor. So there is no point in coagulation the mucosa. Mucosa cannot be coagulated. It is like a vapor, water vapor. There are no spurters from the mucosa. So you see this anatomical dissection has been done by one of my very prominent residents at that time, now my colleague. And you see the beauty of the dissection. This is the pituitary stalk. This is the pituitary gland. This is the chiasma. These are the hypophyseal vessels and things like that. I want to take you to my world of pituitary. And my world is a discrete world of pituitary. And I want to show you what my work on pituitary gland is on the basis of my several publications on the subject. And these publications are shown here. And those who want to see more about my work on pituitary should read these publications. So this is from one of my book chapters, and these are several other book chapters which I have written, and other chapters and letters and all those things. And these are all published. So what I'm going to talk to you is what I have already published and what I have already written quite elaborately. And you can see some of these publications. In neurosurgery, if you ask me which is the most difficult neurosurgery, which is the most dangerous neurosurgery, is surgery on giant pituitary tumors or large pituitary tumors. To understand large pituitary tumors is not easy. And if you really ask me, I have a feeling that very few people in the world, very few, really understand giant pituitary tumors. Giant pituitary tumors are giant by the size, of course, but they remain benign. They are not cancer, they are not aggressive. They are large in size, but meek in personality, but dangerous in surgery. So we have to understand these giant pituitary tumors. Majority of giant pituitary tumors are non-functioning giant pituitary macroadenomas. Small pituitary tumors like microadenomas or smaller than giant usually manifest as acromegaly or Cushing disease. Those are completely different entities. You see, this is Cushing disease, and after operation, pituitary tumor surgery can give new life to the patient. Pituitary tumor surgery is one of the most result-oriented neurosurgery, one of the most elegant neurosurgery. You operate Cushing disease properly and you give new life. You operate an acromegaly patient, you give him new face and new life. You operate a non-functioning tumor, patient has come with visual deficit, and you give him new vision. So it is such a wonderful result-oriented surgery that we have to have great interest in pituitary tumor surgery. So this is Cushing disease patient. No, it is very easy to identify, and tumors here are microadenomas. I have done around 400 pituitary Cushing disease pituitaries, but I'm not going to discuss Cushing disease. This is another patient. You see pre-operative and post-operative. Cushing disease, the tumors are microadenomas. How to remove this microadenoma, whether it is extracapsular removal or piecemeal removal, this is very elaborately discussed. I'm not going to talk too much about Cushing disease. My strategy on Cushing disease is try to remove the whole tumor in one nodule, like Ed Oldfield used to say, and his work is one of the most celebrated works in Cushing disease. So you dissect, and it is extracapsular. You design a plane of dissection between the tumor and the normal, and this capsule of the tumor should be removed en masse. Many a times, because of the soft nature, you tend to puncture it and then it pulsates out, and then you find the wall. Basically, radical resection, total resection gives new life to Cushing disease patient. If you remove 50% or 20%, there is no value. These patients will keep on struggling, and they will ultimately die. So if you do a good operation, you give new life. If you don't do good operation, these patients will die. So Cushing disease is one of the more fascinating chapters of neurosurgery. So this is another tumor, Cushing disease, and this has been removed. And as I have mentioned, my department in my hospital is one of the very well-known hospitals in Cushing disease, because the endocrinologist here in my hospital, Dr. Nalini Shah, is one of the very well-known Cushing disease specialists in the world. So because of her presence, I get many of these patients. So to identify pituitary tumors when there is a dilated stalk like this, whether it is indeed pituitary or not. This is another very important chapter of neurosurgery. Now I am going to show you these kind of tumors. These are lines of tumors, and when I want to show you tumors, I want to show you real tumors, and these are lion-like tumors, and you see the wonderful personality of this lion. If you ask me which is the most handsome animal on the whole planet, and this is the most handsome animal on the planet, and John will agree, I hope. And
Yeah, yes, I do.
pituitary tumor, one of the most handsome tumors of the body. And if you know, if you understand pituitary tumors, you can make this lion turn out into a flower, and you can use it beautifully. So in my hospital, which caters to essentially to poor people, we get many patients coming from all corners of the country actually, or maybe around the country, with huge tumors. And this is the largest meningioma. This is a meningioma, and you see when he came, he had almost 2 heads, and I removed this meningioma, and I had presented with Kawase when he organized a meeting in the foothills of this mountain. And this is pituitary tumor. I want to show you some large pituitary tumors first, okay? So this is one huge pituitary tumor. You just see how the pituitary tumor is going up, how it is going in the cavernous sinus, and how it is displacing the lateral wall of the cavernous sinus. You see the intensity. Just see these tumors. This is another pituitary tumor. You see how it is going behind in front of the brainstem, how it is going up, how it is involving the cavernous sinus on one side, how it is involving the cavernous sinus on the other side. You see the cystic nature of this tumor. This is another giant pituitary tumor. You see another giant pituitary tumor, how it is going up, how it is involving the cavernous sinus. You see the nature of the tumor, the necrotic nature of the tumor, the cystic nature of the tumor. Pituitary tumors are never firm. They are never firm like meningioma. They are soft, vascular tumors. You see, this is another giant pituitary tumor. And I will, as we go, I will show this madness. You see this madness of a pituitary tumor, how it is going, multiple cysts in the tumor, and there is a fluid level in the cyst of each of these cysts, and you see this giant of a pituitary tumor. And I have to tell you that these giants have to be recognized before operation. This is huge, giant pituitary tumor, and you see the madness. And I have to tell you, despite the large and huge size, they are benign tumors. The question is whether you can remove these tumors. This is another giant tumor. You see how it is going. So I want you to just see the relationship with the brainstem, relationship with the third ventricle, this kind of relationship going into the sphenoid sinus. Now you see another beautiful tumor. I call them handsome tumors. You see how it is going here, how it is going here, and how it is going in the region of the brainstem, and how this kind of anatomy, I will show you, I will discuss this anatomy with you properly. And I want to give you the design of this anatomy. You see this another giant pituitary tumor. You see how it is going in the brainstem, how it is involving the various structures, and you see the consistency of the tumor, the nature of this tumor, how it is going in the cavernous sinus, how it is involving the cavernous sinus, how is involving the supracavernous sinus structures. This is another joint. You see how it is going. You just see this tumor and enjoy the pattern of extension. This is another giant tumor. See how it is going in front of the brainstem, in the region of clivus, in the region of diaphragm celli, how it is involving the carotid artery, and how it is going in front and behind and right in the posterior cranial fossa. This is another giant pituitary tumor. See how it is going in the cavernous sinus, in the supracavernous area, and the relationship with the suprasellar structures. This is another giant. See how it is going in the paranasal sinus, how it is going in the brainstem, how it is going in the region of the temporal brain, how it is going in various directions of the. This is another giant with large sella going behind, going up, and going in various directions. This is another giant. So by the time I want to take you to the world of giants, you see how this giant pituitary tumor is going in the paranasal sinuses and how it is involving the clivus and the cavernous sinus and how it is going up. So these giants, majority of these giants are benign tumors. If you remove them, you give these patients new life. Many of these patients come with visual deficit. If you operate properly and nicely, the vision should improve after surgery. More importantly, you can have a disaster, you can have a mortality at hand if you do not treat these patients properly. So now let me describe the anatomy as I have described in the literature. First time in the literature we described, and I think this description has revolutionized pituitary tumor surgery. We described about 25 years ago that when the pituitary tumor grows up, the diaphragm celli, the dura of the diaphragm goes up and the whole tumor is under the diaphragm. And this description, according to me, that when the tumor grows up, it takes the diaphragm celli with it and the whole tumor, it may be suprasellar, but the whole tumor is under the diaphragm. There is no question in my mind that this understanding has completely revolutionized pituitary tumor surgery. You see very clear, this is the diaphragm celli, dura, and this dura is elevated on the dome of the pituitary tumor. Earlier, the understanding was that this tumor, the suprasellar tumor, erupts out of the whole of the diaphragm celli. So this part of the tumor is in the subarachnoid space and this tumor is in the sella. So this was the description. Now we are saying, and there is no question that this is such a wonderful anatomical description, that the diaphragm celli is elevated by the tumor and the whole tumor is under the diaphragm. You will never see, you will very rarely see arteries of the anterior cerebral artery inside this. I will show you those cases, but this is grade 1 pituitary tumor. The diaphragm celli is elevated by the tumor. Even when the tumor goes, you see this kind of growth of the tumor, but the tumor remains under the diaphragm. So this is a very important thing for us to understand, because if this tumor is in the subarachnoid space, then we will not be able to remove these tumors. But if these tumors, the suprasellar extension of the tumor is under the diaphragm, then this diaphragm celli is going to protect you from the intracranial structures and then this tumor can be removed relatively easily. Now you see this is a huge tumor, and the whole tumor is under the diaphragm celli. This diaphragm celli is completely covering the tumor. So if you are operating this tumor, you have to come here and start operating, removal, debulking. These are soft tumors. And ultimately, the whole diaphragm will come into the picture. You don't have to show by beautiful endoscope or microscope the basilar artery. You don't have to show. These are outside, and you will not be able to see because the diaphragm celli is covering it. So these tumors, even if they grow very big, they grow into the sphenoid sinus, they grow up like that. The diaphragm celli has a discrete layer of dura, discrete membrane that separates the tumor from other intracranial structures which are very important, like hypothalamus, like brainstem, and all these structures. And more important for a surgeon is the arteries of circle of Willis are displaced on the dome of the tumor. The cavernous sinus in this case is not involved, and I call these tumors as grade 1 pituitary tumors or grade 1 giant pituitary tumors. These tumors can grow up like this right up till the corpus callosum, can grow up like this right up to the corpus callosum, but there is a discrete dura around this tumor. This tumor is not involving the cavernous sinus, and I call it grade 1 pituitary tumor when the carotid artery is not encased by the pituitary tumor. You see this very clear description. The diaphragm celli is elevated by the tumor, and the whole tumor is subdiaphragmatic in nature. It is not subarachnoid in nature, and this is a very important understanding of this tumor. So this tumor can go anteriorly like this, right beyond the corpus callosum. You see, this image is not such a great quality, but the entire dome of the tumor is covered by dura. And believe me, this understanding that the dura is going to cover this tumor has completely revolutionized pituitary tumor surgery. So grade 1, even when the tumor goes up like this, is completely covered by dura. And the sellar part, the sella is enlarged, and sellar enlargement can become very big, but very often even the sellar dura, of course, but the sellar bone also is thinned out but present. And that is also very important characteristic of these pituitary tumors. And the diagnosis is always made by enlarged sella. So do not distinguish this tumor into a meningioma or any other tumor. This is clearly and very clearly a pituitary tumor. This is another pituitary tumor. It is not encasing the carotid artery. It is not entering inside the cavernous sinus. This is covered by dura, and this artery is in the dome. And there is a well-defined dural layer which separates the tumor with the carotid artery. So this is the tumor, this completely compartmentalized tumor. You see, this tumor is not involving the cavernous sinus. It is going up. The whole tumor is covered by dura. Whole tumor is covered by dura. This artery which is going here is in the lobulations. And when you operate this tumor, you don't encounter this artery. And if you encounter this artery, you have done a philosophical mistake in operating on these tumors. Now you see this nubbin. This nubbin is also covered by dura. This is not outside the dura. This is not The whole tumor is in the intradural space. This kind of nubbin, this large nubbin which is going inside in the region of the brainstem is also covered by dura. The whole thing is covered by dura. The sella is large and it is covered by dura. You see, this tumor is going inside the brainstem. And if you do not have this understanding that there is a well-defined dura, you will never be able to remove this tumor. If you come through transcranial route, you have done a very great philosophical mistake in understanding these tumors. If you do not understand that there is a dural membrane which will protect you during surgery, it is, in my estimation, impossible to remove this tumor. When the tumor goes subfrontal like this was, if you read the books, if you read the journals, and if you ask the people who were operating pituitary tumors 25 years ago, this subfrontal extension was a classical indication of transcranial surgery. But this is also completely covered by dura, and this is post-operative scan. I removed this tumor first from here, debulk the tumor, and the whole dura will then come into your field. You see this tumor, huge necrotic cystic tumor having a nubbin which is going inside the brainstem, having the diaphragm celli going up, having a nubbin here. This whole tumor is grade 1 pituitary tumor. This tumor is going beyond the corpus callosum and has a discrete dural cover, not going into cavernous sinus. I call this tumor as grade 1 pituitary tumor. Many a times there is a large extension into the sphenoid sinus or into the paranasal sinuses. When it breaks out of the sphenoid sinus, when it breaks out of the sella, these tumors are usually more aggressive in nature. In general, the sella is enlarged and the sellar dura is intact in majority of cases. And when the sellar dura is disrupted and the tumor enters into the sphenoid sinus, they are usually more aggressive forms of pituitary tumor. So this tumor is completely covered by diaphragm celli. Many a times these tumors can go into the paranasal sinus and into the nasopharynx. And when this happens, and when it disrupts the dura of the sphenoid of the sella, they are more aggressive forms of pituitary tumors. But many a times, even this large extension into the paranasal sinuses can be covered by thin layer of dura and thin layer of bone. So that is what we must remember. This is another huge tumor with these kind of nubbins, and this is all not going into cavernous sinus. These are grade 1 pituitary tumors. So this is a thin layer of dura, and when you have, this is completely covered by dura. There is no artery within the pituitary gland or pituitary tumor, and that is why I call them a discrete. They have a discrete house of their own, and the neighborhood is quite high profile neighborhood that we have to understand. So we have to, if we have to operate these tumors, we don't have to disturb the neighborhood, which is very high profile, and you can create disaster. If you have to take this material out, you just discreetly enter the house of the sella and the pituitary gland and the pituitary tumor without disturbing the adjoining structures. Now I go to grade 2. You see, this is the internal carotid artery. The tumor is encasing the internal carotid artery. the lateral dural wall of the cavernous sinus is intact. You see, this is the lateral dural wall of the cavernous sinus. The diaphragm celli is intact here. And this tumor is encasing the internal carotid artery going into the cavernous sinus. I call these tumors as grade 2 pituitary tumors. You see, this tumor has now entered into the cavernous sinus. Grade 2 pituitary tumor. You see this beautiful tumor. There is diaphragm is completely intact. The lateral dural wall of the cavernous sinus is completely intact. There are two. This is the side room of the pituitary tumor, and this house, separate house, and there is a carotid artery. Some tumors do not enter into cavernous sinus. Some tumors enter into cavernous sinus. So grade 2 tumors in general, or grade 2 tumor is when the tumor enters into cavernous sinus, are inherently more aggressive than grade 1 tumors. This tumor has entered into the paranasal sinuses and is encasing both carotid arteries and both cavernous sinuses. So these tumors, when it is doing like this, it is inherently more aggressive. Lateral dural wall is, you see, this kind of elevation or lateral elevation of lateral wall of cavernous sinus is a rare phenomenon. Lateral wall is a very thick wall of dura, and elevation of lateral wall is a rare situation. So this kind of pituitary tumor is extremely rare tumor. Now you see this tumor is in the sphenoids, in the sella, and it is going quite heavily into the cavernous sinus on one side, and the whole cavernous sinus is bloated by the tumor. This is the lateral dural wall of the cavernous sinus. It is not transgressing the dural walls of the cavernous sinus. You see, it is elevating here, and this is the diaphragm celli. Some tumors, this is an article which we wrote, that some tumors transgress the medial wall of cavernous sinus, and some tumors do not enter into cavernous sinus. So this medial wall of cavernous sinus dura is a very special layer, and there are many articles written on this subject. This is a cavernous hemangioma of cavernous sinus, as I had talked in my earlier lecture. This is hemangioma. This is not pituitary tumor. It is from, it looks like pituitary, and if you misunderstand this cavernous hemangioma from a pituitary, you go from the nose and operate this tumor, you will certainly create a disaster, because these tumors are one of the most vascular cavernous sinus tumors of the body. These tumors are primary intracavernous sinus. They go towards the opposite side through the intercavernous sinus dura. The whole of this tumor is intracavernous, and I will not like to discuss about cavernous hemangioma in this lecture, because cavernous sinus hemangioma is a discrete entity. They are most benign tumors, and they house like this. The only thing is that they encase the internal carotid artery and go towards the pituitary gland, but not in the sella. This the location is intercavernous sinus dura. We have to understand this very nicely, because if we think that this is pituitary and come from the nose, you can have a very big bleeding disaster. This also, you see, this is a pituitary tumor. This is picture which I published about 25 years ago, and from my same publication, this picture is that cavernous sinus carotid artery is encased but not squeezed by a pituitary tumor. Meningioma will encase the tumor, will encase the carotid artery and squeeze it. And there are some tumors which displace the carotid artery. So there are different tumors and different ways of involving the carotid artery, and we have to understand that. Now I want to take you, so this is the grade 2 pituitary tumors when they involve the cavernous sinus. You see elevation of the diaphragm celli, involvement of the cavernous sinus, displacement of the lateral dural wall of the cavernous sinus, elevation of dura of the diaphragm celli, and lateral dural wall of cavernous sinus, and both the cavernous sinuses are involved by the tumor. You see both. So these are grade 2 tumors. This is another tumor which is, you see the diaphragm and the lateral dural wall is elevated by the tumor. This is going into the paranasal sinuses, and both the cavernous sinuses are involved by the tumor. The diaphragm celli is intact. So these are grade 2 tumors. The diaphragm cell is here, the lateral dural wall of the cavernous sinus is here. The diaphragm can be very badly stretched. You see, it is stretched but not transgressed. In this image, if you see, the lateral dural wall of the cavernous sinus is very badly stretched but not transgressed. So I call it mother dura. Mother dura is encasing the tumor, but mother is mother. It cannot be transgressed. The tumor does not have the strength to go and cut into the lateral wall. It does not have the strength to cut and open the diaphragm celli. Now you see, I want to show you grade 3 pituitary tumors. This is grade 2, this one. Diaphragm celli is elevated, cavernous sinus lateral wall is elevated, and the cavernous carotid is involved by the tumor, encased by the tumor. Now you see beautiful. You see, this is the diaphragm celli, this is the cavernous sinus. The roof of cavernous sinus dura is elevated by the tumor. This is lateral wall of the cavernous sinus. This elevation of roof of cavernous sinus, this is of course, this is not intradural. This is elevation of the roof of cavernous sinus. Very important. I will show you. This is the elevation of diaphragm celli. This is elevation of the roof of cavernous sinus. This is involvement of cavernous sinus, and this is elevation of roof. I must tell you, and you must be very clear in this, this concept was never in the literature before, and even today I hear many lectures on pituitary tumors from all over the world. This concept is not there. And my firm belief is, if you do not have this concept, you cannot operate on such tumors. Now you see here, this is the elevation of the roof of cavernous sinus. This tumor is, this is the diaphragm celli, and this is the elevation of the roof of cavernous sinus, and this is the lateral wall of the cavernous sinus. So this part is intracavernous. When the tumor elevates the roof of cavernous sinus, I call it grade 3 pituitary tumor. I hope you are understanding what I'm saying. I hope my description is clear. So when it is elevating the roof of cavernous sinus here, and when the diaphragm celli is elevated, I call it grade 3 pituitary tumor. Now you see, beautiful. I've got some fantastic slides to show you. This is the elevation of the diaphragm celli, and this is the elevation of the roof of cavernous sinus. This tumor is not, it is intracranial, all right, but it is subdural. It is inside the dura. And this anatomical, if you do not have this understanding, you will not be able to remove this tumor. And this elevation of the roof of cavernous sinus has got very important relationship with the third cranial nerve. So if you make a cut like this of the CT scan, if you make a cut, you will get one nodule here and one nodule here. And both these tumors are, so the pituitary tumor have a method. They have madness, but there is a method in their madness. Now you see this elevation of the roof of cavernous sinus, elevation of diaphragm celli. And if you make a cut like this, you can have three nodules, but all these nodules are intradural or subdural. And these nodules, if you know that there is dura here, you will be able to operate these tumors very nicely. Tumor going into the sphenoid sinus, there is dura here. Tumor going intracranial, there is a diaphragm here. And you see there is elevation of the dural roof of cavernous sinus. There is lateral wall of the cavernous sinus, elevation of the dural roof of the cavernous sinus, elevation of diaphragm celli. You see there is a beautiful, beautiful tumor. And if you do not have this anatomy, you will not be ever able to understand this tumor. This is the diaphragm celli elevation. This is the dural roof elevation. This is the lateral wall. This tumor is inside the cavernous sinus. This is another beauty of a tumor. This is elevation of dural roof, elevation of diaphragm, elevation of dural roof. So if you make a cut here, you will see two tumors, but both are inside the cavernous sinus. So this tumor is inside the cavernous sinus. This is inside the cavernous sinus. It is such important to know that this is inside the cavernous sinus. This tumor you see here, diaphragm, and there is elevation of the dural roof of the cavernous sinuses on both sides. You see this is elevation of the diaphragm celli, and there is this small little elevation is the elevation of roof of the cavernous sinus. This is the diaphragm. This is the dural roof of cavernous sinus. This is the lateral wall. When the dural roof is elevated, I call it grade 3 tumors. Now see this beautiful tumor, which I am sure many of you may not have seen this beauty. I call it Miss India. You see here the dural roof elevation, the dural roof elevation. This is dura, dural diaphragm, dural roof. This is trifoliate pattern of tumor extension, and this madness of pituitary tumor has a beauty in it, this beauty in its methods. You see, this is a complex looking tumor. If you see, this is a very complex tumor, and you will not probably understand this tumor. But if you see it carefully, there is elevation of the dural roof, elevation of the diaphragm, elevation of the dural roof going into the cavernous sinus. And this whole thing is inside the cavernous sinus. This whole thing is inside the cavernous sinus. This whole thing is inside the cavernous sinus. This is the diaphragm celli. This is another huge tumor. You see there is a maddening extension of this tumor. But if you see this, this is the cavernous sinus. You see the elevation of the roof of the cavernous sinus. This whole thing is under the, this whole thing is like under the roof of the cavernous sinus. So these are grade 3 pituitary tumor. Now you see this one. This is the chiasma here, and this is the diaphragm, and this is the elevation of the roof of cavernous sinus. And this roof elevation is hitting the chiasma. This is not hitting the chiasma. So this patient has visual deficits, not by this diaphragm, but by the roof of the cavernous sinus elevation. You see, diaphragm, roof of the cavernous sinus elevation. This is another beautiful tumor, like a small little monkey. This is diaphragm, and this is elevation of the roof of cavernous sinus. This is the lateral wall. This is internal carotid encased. Internal carotid on the other side is displaced by the tumor. This is another beautiful tumor. You see there is a bleeding in this tumor. This is the diaphragm. This is the elevation of the dural roof of the cavernous sinus. Now I want to take you to grade 4 pituitary tumors. I call them, you see these people, these tumors transgress the dura. They violate the dura. Dura mater, dura mother. They behave like malignancy. They do not respect the mother dura, and they go through the mother dura and encase the arteries of the circle of Willis. I call them grade 4 pituitary tumors. You see the artery is encased by the tumor, and these are rare forms of pituitary tumors. Basilar artery encased, suprasellar arteries encased, and when you see such encasement, these are grade 4 pituitary tumors. Now I want to take you to the, so this basically what we described and what we feel has revolutionized the world of pituitary is this diaphragm celli elevated, the dural relationship in the cavernous sinus. Less frequently, these tumors can go into the paranasal sinuses, and when they transgress the dura, I like to call them grade 4. But if you see, they are defined tumors, they are eroding the bones. You see, they're eroding the bones. The bones are not transgressed like nasopharyngeal angiofibromas. They erode and they have a pattern of extension. And the other thing that you have to know is, if you have operated, this tumor has been operated by transnasal route and transcranial route, and once you have operated, once you have violated the membranes, they behave in an aggressive fashion on recurrence. The recurrence can behave in an aggressive fashion, unlike trigeminal neurinomas, unlike facial neurinomas, where the recurrence also is well behaved. But recurrence in pituitary tumors may not be well behaved. So you see how the tumor is going in the paranasal sinus. So if you ask me what approach, whether you will use endoscope or whether you use microscope, even if you put your finger in the nose, you can start removing these tumors. So these are different varieties of tumor. So you see this is another giant tumor going in the paranasal sinus. Here the diaphragm is intact, lateral wall is intact, and even the dura here is intact. So this is my grading system. Grade 1 is when the diaphragm is elevated and the cavernous sinus is not involved. I call it grade 1 pituitary tumors. When the cavernous sinus is involved and the carotid artery is encased, the diaphragm is intact, I call it grade 2 pituitary tumor. Both cavernous sinuses are involved. Here the diaphragm is grade 3 is when the dural roof of the cavernous sinus is elevated by the tumor. These are grade 3 pituitary tumors. And when the arteries of the circle of Willis are encased by the tumor, I call it grade 4 pituitary tumor. So grade 1, in my estimation, no matter how big it becomes, it is a disciplined tumor. Histologically, it is less aggressive. Grade 2, when it goes in the cavernous sinus, histologically, it is more aggressive. When the tumor elevates the roof of cavernous sinus, it becomes more aggressive, and I will show you some images. And when the tumor encases the artery, it becomes almost like a malignancy. So this is my grading system. And this was one article which shows that the anatomy of diaphragm celli, how it has revolutionized the surgery of pituitary tumors. Whether you use endoscope, whether you use microscope, that is such a less important. What you have to understand is how you have to remove these tumors, and the diaphragm celli and the dura of cavernous sinus has to be respected. And there are several articles of mine which I have shown you. This was my initial publication with this grading system. So now I will take you to the surgery of pituitary tumors, how you operate on giant pituitary tumors. And I must tell you that this article which we published was 25 years ago. And at that time, all these giant pituitary tumors were operated by transcranial route. And now I will tell you that transcranial route is not a good operation for pituitary tumors. So this is the uterus of a female body, and this is the fetus. And you must know when this fetus is inside the body, these uterine muscles are the strongest muscles of the body. Do you know which muscles of the body are the strongest? You will think that the biceps are the strongest, or the shoulder muscles are the strongest, or the thigh muscles are the strongest. No, the strongest muscles of the body are uterus. And uterus has the power to push the fetus out. You see, the uterus, the natural course of baby to be delivered is by a transvaginal route. Have you ever heard an elephant being done cesarean section or a horse being done a cesarean section? The uterus of these animals have the power to push the baby out. That is a natural design power. Similarly, this dura has the strongest, it is quite strong and quite powerful. So basically what you have to do is, whether you use endoscope or whether you use microscope, that is very, very flimsy. You open the anterior wall of the cella. You don't have to open the planum sphenoidal or extended approach. I do extended approach. I do very extended approach. I want this exposure. Absolutely do not. You do not understand only pituitary tumors. What you need is just open the anterior wall of the cella, which is large. Start debulking the tumor, debulking the tumor, debulking the tumor, debulking the tumor, and go in this direction. There is very rarely, of course, sometimes you have to open this part of the bone, but extremely rarely. Debulk, 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 and very soon you will find the whole diaphragm coming into the picture, and it will bulge into your field. You must know how to go on the walls of the diaphragm celli, and you will have this beautiful post-operative scan. And many of these tumors can be debulked. Learn the art of demolishing these tumors. Learn the art of breaking these tumors. These tumors are large, but they are vascular and they are soft. If you go on coagulating in these tumors, you cannot remove this tumor. If you think I will get a bloodless wheel, you do not know how to operate on pituitary tumors. These tumors have to be demolished and they have to be broken. Break the tumor, break the tumor, break the tumor, break the tumor. And these are soft tumors. Use suction, use biopsy forceps, break the tumor, and ultimately the whole diaphragm cell will come into the picture. And you have not seen these vessels, you have not seen, and if you have the whole diaphragm, you may not even have to repair. You don't have to put fat. Nowadays, I put fat more often. But if the whole diaphragm is here in your picture, this is a completely extracranial operation and you don't have to repair. I use endoscope, I use extended endoscope, and you come from here and you see the anterior cerebral artery, you see anterior cerebral artery perforator, more often than not, you will damage this person. So to understand the anatomy of diaphragm is very important. You see, this is, I will say, I don't remember these cases, but you see, there is a fluid, there is soft tumor. I will remove this tumor in exactly 15 minutes or less. You come, open the anterior wall of the cella, break into the tumor, break into the tumor. This will come out beautifully in no time. Then the cyst will come out and the whole thing has come out and you have not seen anything here. Those who will like to show the anatomy with endoscope of the aqueduct and a brain and corpus callosum, those people do not know pituitary tumor surgery. You do not have to show anything, because you cannot show anything if the diaphragm is going to be intact, and the whole diaphragm should come into the picture. This is another tumor. You see the large sella, open the anterior wall of the sella, break into the tumor, learn the art of delivery. You have to be a gynecologist to operate on pituitary tumors. If you say, I am a general surgeon, I will do cesarean section, I will do this section. No, you have to know the art of delivering this child. Anterior wall of the sella is removed, demolish the tumor, and the whole diaphragm should come. I think this tumor resection should not take more than 15 minutes, and the whole. More important is, many of these patients come with history of visual deficit. These are benign, non-functioning tumors. You remove them completely, and you remove them in the evening, they improve in the vision. You see, there is a nubbin here. If you think that this nubbin this is completely dura, break the anterior wall, demolish the tumor, debulk this tumor, and you remove this tumor. There is some tumor remaining here, but as I mentioned to you, these are not aggressive tumors. Whether to give radiation or not for this tumor is a very questionable. I will discuss about radiation very soon. So when this tumor herniates, like in the sphenoid sinus more, this becomes much more easy. You come from here, break the anterior wall, debulk this tumor, and then you have a huge space to remove this tumor. So whether you use endoscope or you use periscope or you use telescope, that is different, or you use microscope. But more important is that you should know that the diaphragm is going to be here. The arteries are going to be separated by the layer of diaphragm. You demolish the tumor, debulk this tumor, and the whole diaphragm will come here. You don't have to see this artery. You don't have to see the pituitary stalk. You see this huge tumor going in near the brainstem. If you have the anatomy that this tumor is completely in defined membranes, debulk the tumor, debulk the tumor, debulk the tumor, and the entire tumor is removed and the patient is cured. Patient is completely cured. You see this tumor going right up to the corpus callosum. You can come transcranial. You can come from posterior fossa. That is immaterial. But what is the beautiful approach is come from the nose, remove the anterior wall of the sella, learn the art of delivery of this child. And this child is an absolutely benign child. Once you remove this, this gentleman is completely cured. And this, you see this tumor can be, this is immediate post-operative. There is a lot of fat here. I don't have to put so much fat, but this is for reconstruction. And there is no dural opening here. This, I will say, is one of the easiest tumors. You see such a large belly of this tumor and small head. Open the belly and you have a huge space, and then you remove this tumor. To answer your question, I do not use endoscope. I do not like endoscope for pituitary tumor surgery because it is not necessary. No matter how big the tumor is, can be done by conventional transsphenoidal approach, which I use. This is another tumor with a huge belly. Open the belly and deliver the child. Open the belly, first remove, this is breech delivery. First debulk this, debulk this, debulk this, and then you see there is cystic necrotic. This is soft tumor. And if you think that this tumor surgery will take more than 5 hours or 10 hours, then you do not know this operation, how to do this. You should not do only this operation. This tumor should be removed in 15 minutes. And if you are less than experienced, then you may take half an hour. But if you say, I will remove this tumor in 5 hours, then you will go on coagulating and you will demolish the whole story. This anatomy should be beautifully delivered. So there is a lot of controversy. I wrote this chapter for Al-Mafti's book, whether to use endoscope or whether to not to use endoscope. And my argument was, you can use any scope, but what should be in your scope of mind is the understanding of the dural membranes. And I mentioned in this article that I do not use endoscope for pituitary tumor surgery. Now I will show you some of the more beautiful cases. 1998, I removed this tumor. 1998 means 23 years ago. You must imagine 23 years ago, pituitary tumor was not so much established. Endoscope as an instrument was not established 23 years ago. And I removed this tumor by transnasal route by the understanding that this is completely covered by diaphragm. And this is post-operative scan. You can imagine 23 years ago, the whole tumor was removed in very quick time with the understanding that the diaphragm is, if you do not have this understanding of diaphragm, you just cannot remove, whether you do transcranial or transnasal, you will not be able to remove this tumor. This was, I removed 20 years ago, you see, in the year 2000. And this was the post-operative, this is post-operative image showing some fat. This is another tumor. You see the diaphragm cell is elevated right up to the foramen of Monroe, and you remove the anterior wall, debulk the tumor, and you have fat, and you have a person who is cured. You have normal vision. You have intact vision, improved vision. You see this tumor, remove the anterior wall. Don't have to do anything with the plenum sphenoid tuberculum celli. Anterior wall, learn the art of breaking the tumor, and you have a beautiful anatomy post-operative, and you have a person who is cured. This is another tumor. You see, this is going like this, right up to the corpus callosum. You may prefer transcallosal, you may prefer intrahemispheric, but the best approach is just anterior sellar wall removal, debulk the tumor, and you have the whole tumor coming into the picture. And this is post-operative, immediate post-operative scan. This is also immediate post-operative. You see there is a nubbin here and there is a diaphragm here. You remove the anterior wall and you just debulk, and the whole tumor is out in a very quick time. This is another tumor. This is, you see, going up like this, and the tumor is removed on the premise that the diaphragm cell is going to be protecting you. Diaphragm cell, necrotic tumor, debulk this tumor. I don't want to, you see, unfortunately, my videos are not working today somehow on this screen, but hopefully I will show you. The diaphragm is elevated, necrotic tumor, anterior wall removed, and the tumor has been demolished in quick time. You see, going in this direction. Now you can come transcranial. You nasal, I want to use this, I cannot see this, I will use this direction, I will use 0 degree, I will use 80 degrees endoscope to see this part, no 80 degree or 20 degree. You come here, remove the anterior wall, demolish, and this like a pulp, the whole thing will be removed, and this will be post-operative image. This is another diaphragm, and this is diaphragm. This is another huge tumor. This is immediate post-operative image. The diaphragm is going to be present. Remove the anterior wall of the sella, and this tumor can be removed. And you have to know that you have cured the person. This tumor I removed just in COVID time recently. You see, going into the brain stem like this. Even this tumor I have removed just recently in the COVID times, and the whole tumor has been removed just few months ago. Now you see this tumor, if you do have the understanding that the diaphragm is present, you can remove this beautifully, and this is post-operative scan. The whole tumor is removed without seeing the basilar artery. And I have to tell you, and you must remember, that those people who like to use endoscope and show the anatomy after surgery, see basilar, see perforator, see anterior cerebral, those people do not know pituitary tumor surgery. You cannot show anything because nothing will be seen because diaphragm is there. You see this diaphragm, and this is post-operative, some residue here probably. I don't know about this case. Many of these cases have been given to me by my resident who gave me this for my presentation. So this is also in the COVID times recently, this tumor, necrotic tumor. This is blood here, which will soon disappear into wilderness, and there will be this patient is completely cured. You see this tumor, very straightforward tumor, and this is post-operative, this diaphragm. These are post-operative. You see, after some blood goes and there is a little bit bulge here, but after some time, after 2 or 3 months, the whole thing will fizzle off. You see, this is the tumor. This is the diaphragm remaining tumor in the sphenoid sinus. This is another huge and beautiful tumor. Believe me, also done very recently. Remove the anterior wall, demolish the tumor, demolish this large venous complex. These are not intracranial arteries of the circle of Willis. These are vascular tumors. Large tumors are large because they eat more. What is their food? Blood. And they are more vascular tumors in general. But aggressiveness is not, they are not, they are benign tumors. Now you see this tumor I had removed in the year 2001. 20 years ago. This was my anterior approach. You see, this was the approach. I left some tumor behind. This is some tumor. I could not remove this part of the tumor. Some tumor was left behind. Now in 2001, this has increased. So now my policy is when the tumor is more than 5 centimeters, and if I have left some tumor behind, I like to give radiation treatment for this. So this residual tumor, normally I don't give radiation, but if the residue is if the tumor size is more than 5 centimeters, I like to give radiation treatment. This is another tumor I did in the year 2001. You see this tumor? Now the understanding is the diaphragm is intact, diaphragm is intact, diaphragm is intact. Remove the anterior wall of the Sellas, debulk the tumor, and you see you have removed the whole, this is blood in the postoperative period. This gentleman disappeared, never returned, and he returned in 2008 with a recurrence. So now my policy is when the tumor is more than 6 centimeters, and even if I have removed the whole tumor, I will give radiation treatment. So these are my changing understanding, like 6 centimeters and 5 centimeters. This is the tumor, and I want to show you some pre-operative and post-operative imaging, see how it is going in the brainstem and how it is having these kind of lobulations, and these are post-operative scans. This is another tumor where I had to do transcranial. So the answer to the question is, I do not normally do transcranial surgery for this, but in this patient, I did transcranial surgery. I could not remove this part of the tumor, so I did this removal by transcranial method, and that is also done very recently. About cavernous sinus. See, this was a very interesting case. You see, I removed this tumor. This is a non-functioning tumor. The patient improved in the vision. I left some tumor behind in the cavernous sinus, and I did a scan after few months, and this cavernous sinus portion of the tumor disappeared. And I had published this in 15 years ago, the spontaneous resolution of residual pituitary tumor. So the policy is in non-functioning tumors, you don't chase the cavernous sinus unless the tumor is soft and unless you have a clear definition and you want to go in the cavernous sinus. You don't have to remove this part of the tumor, because basically these people come with visual deficit, and once you remove the tumor, of course, if you can easily go into cavernous sinus, you must. Like this tumor, I tried to chase into the cavernous sinus. There is some residue here, but majority of the tumor has been removed by transnasal route. So you have to learn how to go move your speculum and go into the cavernous sinus, and how to identify the carotid artery, and how to avoid injury. So you don't have to use any sharp instrument in pituitary tumor surgery. If you say, I use micro scissor, I use micro dissector, you don't have to use, my dear friend, any micro dissector or micro scissors. These are soft tumors. You have to use softness. You have to show your soft side of your personality and work within the tumor and remove this tumor in a soft manner. No firm or hard dissection. So this is another tumor which I'm showing you some residue in the cavernous sinus. This is another huge tumor. This is also recently done, and I tried to attack this cavernous sinus, this roof of the cavernous sinus from here, and there is some residue here. This is recently done. I will think about what is to be done. There may be some blood here because this is maybe some blood. So I will do a repeat scan after about 3 months and then decide what is to be done. This patient has also remarkably improved in the vision. Now this is the elevation of the roof of cavernous sinus. So you go into the cavernous sinus and then turn your microscope and go into the roof of the cavernous sinus. And the dura will protect you. This dura will protect you. And you have to be very gentle here. Don't use any sharp instrument. If you have enough space in the roof, you go into the and use thin suction to go inside the cavernous sinus roof, and it is possible. This I've shown you. This is both cavernous sinus, and there is residue in both the cavernous sinus. What you do now, I want to show you residue in the roof of cavernous sinus. You see, this is the roof of cavernous sinus, and there is, I have removed this midline part which is disturbing the chiasma, but the part in the roof of cavernous sinus I have not removed. Now my strategy is, if I have not removed and the person has improved in the vision, I will like to give these patients radiation treatment. Now in 2003, I did this tumor. You see this. This is elevation of the roof of cavernous sinus, elevation of diaphragm, and this part, elevation of roof of cavernous sinus, has not been removed in 2003, and in 2009 there is a recurrence. So now my strategy is, when the tumor is elevating the roof of cavernous sinus, or when it is grade 3 tumor, I like to give radiation for these tumors. So this is another tumor. You see there is elevation of dural roof of cavernous sinus. This is diaphragm celli. This is having nubbins, and this tumor has been completely and radically removed. Some residue in the cavernous sinus. I have not done any post-operative radiation, and I don't want to. So this is the elevation of diaphragm. This is elevation of the dural roof of cavernous sinus. You see how I have entered the cavernous sinus and how I have removed the tumor from underneath the dural roof of cavernous sinus. This case was also done by me several years ago on the understanding of the anatomy of the dural roof. This is another beautiful tumor that you can see the elevation of the roof of cavernous sinus. This is blood in the roof of cavernous sinus, and there is blood under the diaphragm, and I'm expecting.
Okay. Just hang in there. Usually the Wi-Fi recovers.
And what is the technique of removing diaphragms? Reserved, and this tumor has been removed, and some tumor is remaining inside the cavernous sinus. This is another tumor. You see the tumor in the cavernous sinus. I have tried to remove. Some tumor is remaining, but majority of the tumor is gone, and this patient was subjected for radiation treatment. This is another beautiful tumor which is elevating the lateral wall of the cavernous sinus like I have never seen before. And this tumor was removed by transcranial route. And this patient was subjected to radiation treatment. First nasal route was done and then transcranial. And this patient was subjected to radiation treatment subsequently. This is inside the cavernous sinus, you can imagine, was removed by transcranial route. So a transcranial route is used by me very uncommonly, very rarely, and when I have extensions like this. This is another tumor. Beauty of the tumor, you can imagine. This is elevation of diaphragm, elevation of roof, cavernous sinus involved. I have entered into the cavernous sinus, but I did not remove this part of the tumor. And you see, I have entered and removed some of the cavernous sinus. This is also very early in the post-operative period. And this patient, obviously now I subject him for radiation treatment. This is another tumor. You see removed. Part of the cavernous sinus has not been removed. Rest of the whole tumor has been removed. This is another tumor. You see how the tumor extension, my resection is going inside the cavernous sinus. This part is not removed. This part, whether to do transcranial now is a question. This is another tumor. You see elevation of roof of cavernous sinus, elevation of roof of cavernous sinus. I removed this tumor and both the elevations of the roof were not removed. So I subjected this for radiation treatment, and after several years, this was pre-op and this is after several years, there is some residue in both the roof of cavernous sinus, but this patient is completely and entirely intact and with very good vision without any major issues. This is another tumor where I have introduced fat, and this is some blood here. This is not tumor residue, and this has been very beautifully removed. Now, grade 4 tumors. What is your strategy of when the tumor is encasing the arteries of circle of Willis? Like this, you see, I call it cobra tumor. You enter into this tumor and you damage one perforator and you kill this person. So what to do about these tumors is still under my discussion. I like to do a little bit controlled dissection in these tumors. This tumor is encasing both internal carotid and ICS, and you enter and you try to remove this tumor completely. There is a big possibility of a disaster. Now I want to take you to another dimension. See, some of these grade 4 tumors are like this, grade 4. And many of these grade 4 tumors, like this tumor, this is grade 4 tumor, are prolactinomas. And even when the tumor is, prolactin level is not very high, if it is in a, prolactin level is little bit high in all giant tumors. If it is moderately high, say more than 50, 60 or 100, you think that it is not a prolactinoma. You give this patient Cavernous. And this patient was given Cavernous, and you see this tumor disappeared on drugs. So many of these grade 4 tumors are prolactinomas. This is another huge tumor. This is a prolactinoma and treated without surgery with drugs. You see this prolactin level in this tumor was 32,500. And of course, when you have such a large high prolactin level, these are grade 4 tumors. So prolactinomas can sometimes become very high grade and use these tumors. You see this high grade tumor was treated with drugs and no surgery was done on these tumors. So this is another case of high, very high, you see, this was short stature, poor sexual characters, headache, proptosis, was started on Cavernous, this tumor, and this tumor has, prolactin was not very high. And this is post-op, no, this is very high. It is actually 18,740. and this is 400 now remaining, and treatment on drugs. So many of these grade 4 tumors are actually prolactinomas. So when you operate on giant pituitary tumors, there are 4 danger issues, 4, and these are 4 or 5. One is very big tumors. And if you have done partial resection, they bleed. So you have to demolish the tumor. If they are very big, it is a danger issue. Higher grade tumor is a danger issue. And when the patient is coming to you in a drowsy state, it is a danger issue. You can kill this person. When this patient has come with altered behavior and altered consciousness, they are danger issues. And when the patient comes with hypothalamic disturbances, these are danger issues in giant pituitary tumors. So when should we give radiation to these tumors? One is for grade 4 tumors. When the grade 4 tumor, you must give radiation. When grade 3 residue, when grade 3 you remove this tumor, and if there is a lot of residue in the roof of cavernous sinus, I give radiation treatment. In grade 1 tumor, when the tumor size is more than 5 centimeters, even if I have left some tumor behind, even if I have completely resected this tumor, I give radiation treatment. And recurrent tumor, I like to operate, and if there is a residue, even after recurrent tumor, I like to give radiation treatment. So that is my strategy for dealing with residue. So I'm just showing you this reconstruction using vascularized pedicle flap, which I had described. And recently, we have now started studying, and one of my papers is coming out very soon with my team, of course, proteomic-based investigation with Indian Institution of Technology in Mumbai, where we have studied the proteomics of each grade of these tumors, and we are coming out with these studies. And all these studies are very meticulously studied with various protocols which are described. Now I want to show you rapidly the cysts of the pituitary tumor, how the cysts are formed. You see, these are the cysts in the pituitary tumor. When there is a cyst, obviously it is more aggressive. When there is no cyst, it is less aggressive. So this cyst, but it makes your surgery much more easier and much more simpler. So this is one cyst. Now I want to show you this cyst, which article which I had published, fluid level within the cyst in pituitary tumors. So just see the beauty of these cysts. So this was the article which I published 10 years ago on my experience with 106 cases 10 years ago. Now my experience must be around 300 cases. You see, this is the tumor, and you see there is a level. You see this level? This is fluid level within the cyst. Now you see there is 2 cysts, and both these cysts have a fluid level. Now you see a huge tumor, and if you see carefully, each of these cysts has a fluid level. Can you appreciate? I'm not sure if you can appreciate, but there is a fluid level in each of these cysts. You see there is a fluid level in this cyst. There is a fluid level in this cyst. Now this cyst has a fluid level here, and there is a fluid level here. Now if you ask me this tumor, you operate on this tumor, this is a most easiest tumor to remove. You operate, there will be dark blood-like structure, fluid which will come out, and the whole thing can be removed in quick time. If I say half an hour for the other tumor, I will say not over maybe 5 minutes for this tumor or 10 minutes. You remove this tumor, this fluid will be drained, and then you remove the wall of the tumor. So there is a fluid level. It is easy to remove, but these tumors are more aggressive in their behavior, and the recurrence rate is much higher. So you see there is a fluid level here, there is a fluid level here, and there is a fluid level here. So these tumors are easier to remove, but they are histologically more aggressive. You see, this tumor looks very aggressive and large, but it is huge fluid, and there is a fluid level of different consistencies in this tumor. So you come, remove the anterior wall, debulk the tumor, this will be delivered, and then you remove the wall of the tumor, which is reddish in consistency, and you see this beautiful fluid level in this tumor. Majority of this tumor is fluid, and this fluid level makes it easier to remove, but more difficult. The behavior is more aggressive. You see, there is a fluid level here, and there is a fluid level here. So this fluid level, you remove the anterior wall, debulk the tumor, this fluid will be removed, and then the dura will be seen. Some tumor will be around the wall. Protect the dura. Learn the art of protecting the dura. Learn and understand the dura, and the whole tumor can be removed in very, very quick time. You see, there is a fluid level here. There is a fluid level here. This tumor is a beautiful pituitary tumor. You see, this tumor looks quite big, but if you see, there is a fluid level in this tumor. Now, I was showing you this tumor early in my presentation, and I wanted you to see this. But now I want to show you the beauty in this madness. You see, all these cysts are having a fluid level. Can you see all these cysts are having a fluid level? And I will rate this tumor resection difficult, but not impossible. This tumor can be removed in quick time because these tumors, the cyst will come out. You see the fluid, these are fluid levels. These are various layering of the fluid. You see now this tumor, and if you carefully see, there are many cysts with fluid levels, fluid levels, fluid levels, fluid levels. You see this tumor with multiple fluid levels. And if you operate, if the tumor will recur, now you see this beauty of this tumor. If this tumor will recur, the recurrence will also have a fluid level. That is the most astonishing part. We have to admire the beauty of nature, admire the beauty of these tumors. You see the fluid level, the whole tumor is fluid and nothing but fluid. The wall of this tumor is vascular tumor. You remove the cyst, and then the wall of the tumor from the dura, you gently suck that wall, and that is the tumor. You see this tumor in the cavernous sinus also, there is a fluid level. Now this tumor should be removed. You should not leave this tumor behind because this is easy to remove. Enter into the cavernous sinus and remove this tumor. And if you say, I want to use this tool and that tool and I will show you the anatomy, no anatomy. You come from here, open the anterior wall of the sella, open the anterior wall of the cavernous sinus, open the dura here, learn the art of anatomy, learn the art of demolishing the tumor from tricky space. If you start coagulating within the cavernous sinus, then my suggestion is that you should not do cavernous sinus surgery or pituitary tumor surgery. These tumors, there is no need for coagulation. So this is the beautiful layering of this. Now, beautiful, most beautiful. You see the beauty of layering, and I'm sure all the people watching this presentation will enjoy the beauty of pituitary tumors. I said lion is the most beautiful animal, but I will say pituitary tumors are the most beautiful tumors. And you see this tumor have multiple small cysts all with fluid levels. You see this tumor has a beautiful fluid level, and you must enjoy this fluid level. This tumor which I showed, I did it in 1988. Because there was a fluid level, I could remove this tumor beautifully, and the whole tumor, which I showed earlier in my presentation, and this fluid level makes this a fantastic tumor. 1 level, 2 level. This tumor which is going inside the cavernous sinus, I remove this because there is a fluid level, and this makes your resection easier under the diaphragm fluid level. So you have to know the quality of these tumors, and this tumor multiple cysts with multiple fluid levels. This tumor I showed you already, and this is the post-operative scan showing tumor resection. This tumor is, according to my calculation, a very straightforward pituitary tumor to remove if you know that these fluid levels, but the chances of recurrence are much higher. So you see, this is the pre-operative with the fluid level, and this is a recurrence with the fluid level. Now you go again and remove and then give radiation. Whether you want to give upfront radiation is another question. So I have described fluid levels in various tumors, including schwannomas, acoustic tumors, various schwannomas I have described. So when you see a pituitary tumor, you should first understand the tumor. You must first know the tumor. You must first know the dural anatomy of this tumor. And if you have some difficulty in understanding, you must see this article of mine, which was published about 15 or 20 years ago, and you will enjoy reading these tumors. You must also know that these tumors should be removed radically. These tumors should be removed aggressively. And if you leave some tumor behind, there is a possibility of fatal post-operative pituitary apoplexy. The residual tumor will bleed, and it will bleed to death. I described this 25 years ago, this entity of fatal post-operative pituitary apoplexy. And many people have used this terminology, and only some have referred to this article, but this was published 25, 26 years ago. So cavernous sinus and pituitary tumors are a beautiful subject for neurosurgeons. Life-giving, vision-giving operation. We have to learn and enjoy this operation. We have to learn the art of breaking these tumors. We have to learn the art of working in bloody field. We have to learn the art of removing the tumors without coagulation, and you will give new life to these people. And now rapidly I'm showing you some tumors which I showed you early in my presentation, where you had some difficulty in understanding these tumors. Now you can understand that this is under the diaphragm, this is inside the cavernous sinus, this is large tumor with cyst, multiple cysts. This is not a glioblastoma or a malignancy. This cyst with fluid level is a pituitary tumor. It is coming in the sella. This is a soft tumor. Break the anterior wall, and believe me, you will not get such pleasure in any neurosurgical operation than operating in this tumor. So there is a method in this madness, and that method has to be understood. That method has to be exploited, and that method has to be exploited in the favor of our patients. These tumors can become large. These tumors can become huge. These tumors can become aggressive. If you know how to remove, you give new life to these patients. Thank you very much, my dear friends. And if you have any questions, of course, you are. Over to Yuha.
Thank you, Atul. It was a tremendous series of cases. That kind of cases we see a few in a small country in lifetime. So this is huge selection and huge experience. So we have to draw our conclusions from this great series, and especially the anatomical part, grading of this case is very important for treatment. So we have to be extremely grateful for this wonderful lecture and series. And I open the discussion. I hear from John Bennett. There are some questions in the chat box.
Yes, you have.
Please go ahead. Yeah.
Okay, there's a question from Mohammed Helmi. Mohammed, do you want to ask it directly, or you want me to read it? Mohammed, you there? Well.
Yeah, okay, John, let me answer this question from the chat box.
Okay.
He's asking me about prolactinomas and whether you need to operate on prolactinomas. And my answer to that question is, in majority, this is now you mark my word, majority of cases of prolactinomas can be beautifully treated with drugs. And it should not be that you have not tried drugs before you operate. There are some cases of prolactinomas where even if you have given drugs, the tumor remains large and there are visual deficits. In that situation, you might like to operate. But in general, to answer your question, I will say that prolactinoma should be treated by drugs always, at least as a first line of defense.
Okay, very good. There's a question from Talik Salem. Thanks, Professor, for your enormous experience sharing with us in this lecture. My question is, what are the exact MRI findings to differentiate between grade 3 and grade 4 of pituitary classification?
Yeah, Tarek, I had shown this with several slides. You see, grade 3 are grade 3. In my definition, grade 1, grade 2, grade 3 are benign pituitary tumors. In my definition, grade 4 is aggressive. I don't want to use malignant because malignancy is a wrong word. Even when they become grade 4, histologically, they are not malignant. I don't like to use malignancy as a word, but grade 4 are much more aggressive than grade 3. So we have to differentiate between grade 3 and grade 4. Grade 3 remain within the dural confines in a box. They have the house, they have the mother protecting from all around. Diaphragm protects it, lateral wall of dura protects it of cavernous sinus, and the elevation of the dural roof of cavernous sinus protects. So the whole tumor, grade 3, is in a compartment of dura, which is not understood, which has never been reported in the literature. And that is the beauty. Grade 4 is when it goes beyond the dura and encases the arteries of the circle of Willis, that becomes grade 4. And that is when the tumor becomes a difficulty whether to operate or not to operate. Then it becomes a situation where how much to operate, whether to operate, I am actually working on this subject, and I will come back to you on this subject with a new paper very soon. So just hold on and wait for that time.
Okay, we have another question from Tariq Salem. What are your limits in acromegaly for transnasal surgery with narrow carotid space?
You see narrow carotid space or no narrow carotid space. There is always a space. So even if there is a narrow space or whatever space, you have to understand and evaluate that space. We have got several cases where the carotid arteries are almost touching, but you can develop your corridor and a space and go inside. I too, I don't know of what kind of situation you are talking about, but I have never had a situation where carotid artery in the sella has obstructed my exposure and made me avoid this exposure and go transcranial or any other route. Acromegaly can also become giant. Acromegaly tumors are giant, all right, but the patients are giant, all right, but the tumors can also become giant in acromegaly. Tumors may remain small and the patient may become giant. Tumors may become giant, but the patient may remain small. Or patient will become giant and tumors can become giant. So there are various permutation and combination. In general, giant acromegalics the tumors are very bad and nasty tumors, but you have to go and remove it radically. There is no other option because drug treatment is not a possibility in acromegaly like in prolactinomas. Cushing disease, we have recently published some papers on Cushing disease and large tumors. Cushing disease are usually microadenomas, but sometimes they become macroadenomas. And when the Cushing disease are macroadenomas, the outcome is little worse than when it is microadenoma. So recently, if you want to know details about Cushing disease and outcome, you can go through my paper because it is published by our endocrine department. And as I mentioned to you, our endocrine department is one of the most prolific endocrine department with very, very huge experience in Cushing disease. And that has given me an experience of nearly 400 cases of Cushing disease in my career and more than 5,000 pituitary tumors. So that is my power, and that is the basis of my presentation. John?
Yes. Do you see any more questions, Juha, on the panel? I don't see any more.
So, John,
Uh,
I'm asking you,
Hello,
which is the
hello,
animal?
Professor Go.
Yes, Ben.
Hi. Because you treated so many giant adenomas. Sometimes, especially the ICA. Did you ever encounter that when you remove the adenoma, the hurt the ICA, then the ICA can, begin to bleeding?
Yes. So this is a very important question that Ben has asked me. You see, in this Ben, in this presentation, basically, I wanted to give the anatomical description of these tumors. Basically, I'm not presenting on the complications and dangers and all those things. I have not presented. Now, this situation, when the carotid artery is ruptured during the operation, you are operating from the nose and carotid artery bleeds, it can become a very, very dangerous situation, as you can imagine. At that point, what you have to do is, one is try to control the bleeding, try to find that small spot and try to coagulate and things like that. And sometimes if you are having a very wide exposure, you can even try to make a suture. I have tried, but I have never been successful to suture the rent. I've never been successful. I have tried. But I have seen some people showing suturing. But it is, according to me, very difficult. I will say in my entire experience, I have had at least 4 times injury to the carotid. Now I will give you my experience how to deal with it. So what you do is, when there is a carotid artery bleeding coming in the whole field and that the whole field can become blood, so you have to pack that with Surgicel and with gel foam and all these things, pack very strongly. And immediately, you have to take the patient to the angiographic route for angiogram and occlude the carotid artery. When the carotid artery has bled and you have packed, it is sometimes difficult to occlude the carotid artery from here, from the nose. You take the patient to the angiographic suite, do an angiogram and see the carotid artery. You will always find a pseudoaneurysm, always. And if you have not found the pseudoaneurysm and the bleeding has stopped and you discharge the patient and you send the patient home, this patient will return in 1 week with a nasal bleed. So when there is a carotid artery bleeding, it is always essential to either try to put coils in that pseudoaneurysm, which one of my radiologists tried, or to put coils in that pseudoaneurysm, or to occlude the carotid artery. This carotid artery bleeding from the nose, when it happens during your pituitary tumor surgery, it means the carotid artery has to be sacrificed unless you cannot sacrifice. Then you have to put stent and coil, which recently, you see, I am talking of a situation. One patient, I had ruptured the carotid artery, it bled in the field. And then I packed with gel foam and Surgicel and all those things, and I sent him home. This patient returned in 1 week with a large bleed Then I did angiogram and pseudoaneurysm. At that time, I'm talking of 10 or 15 years ago. That time we had done balloon occlusion of the carotid artery. But now, of course, you can put a stent and you can put coil and preserve the carotid artery. But this carotid artery has to be dealt. Now I will say you don't even send the patient home till you have dealt with the carotid artery if the carotid artery is definitely ruptured during operation. What do you think, Ben? What is, do you have some experience in this?
Yes, I treated this condition for 2 times. Both I use a covered stent to stop the bleeding and save the ICA.
Yeah, you can save
Yeah.
the ICA now.
Yeah.
But you know, earlier days when we were in the
Mhm.
earlier
Yeah.
time, the stents were not there.
Yeah.
And I had bleeding, that time it was balloon occluded and one time coils were put. And more recently, about 1 year ago, my interventional radiologist had put a stent and coils. So when the artery has bled, carotid artery has bled, you have to deal with it. You cannot just pack it and leave it.
Yeah, if the collateral blood flow is not enough, you may be combined with the bypass.
Yes, yes.
Okay,
That is
Yuha,
Binzu will do
Yuha,
first.
oh, I'm sorry. Go ahead, Atul.
No, Binzu is the bypass king. So he,
Yes. Besides being a translator, he's the bypass king.
yeah,
Okay,
yeah.
Yuha, what would you like to do? Continue to ask questions, or let me get you unmuted there, Yuha. Unmute yourself. Yuha, could you please unmute? You're muted there, Yuha.
You are muted.
There was one important question about the closing, about the, you mentioned fat transplant, but also about mucosal flap, or can you
Yeah.
explain that?
Yes.
Closing,
Now, you
very
see,
important.
now I must, this is very important about how to close and when to use what. So now, you know what, initially I was saying when the diaphragm is intact and the diaphragm herniates into the picture, I mentioned in my lecture that you don't even have to do any introduction of fat. My indication for introduction of fat is during operation, when I am operating, and if I see any CSF during my operation, whether it is from the diaphragm celli or from wherever, when I have toned the diaphragm and CSF comes in the picture, I will put fat always. And when I am doing microadenomas like Cushing disease, I was avoiding putting fat. I think that is a big mistake in Cushing disease. If you are not, in most of the Cushing disease patient with microadenomas, I always pack the sella after removing of the tumor with fat, and then the sphenoid sinus with fat, and I introduce all the bone graft, all the bone which I have collected, I put there. Regarding the mucosal flap, it is a beautiful flap and can be used on occasion, but I depend more on fat. And fat is the best material for reconstruction. You see those people who are using endoscope, and then they are doing a lot of work on the nose, on the turbinates and on the mucosal layer and on the septum, and then they use Haddad flap and all those things. When you are doing transnasal speculum-based surgery, like Hardy's, you are doing microscope-based surgery, you don't have those kind of issues because you are separating the septum, you are going to the warmer, you're opening the sphenoid sinus, and you have not touched the mucosa at all. You have just displaced the mucosal layers. And you reach the sphenoid sinus, open the dura of the, you think I will like to show one video if possible, although it is completely just few days ago I had done, and it is not edited at all. So would you like to see that?
Okay.
Let me
Great. Yeah.
But you must remember it is not edited at all. So don't start criticizing me, Bin, and enjoy it. Let me show you. Wait. I'll have to. Can you see my screen?
Yes.
Yes, yes.
Okay, let us see now. See, this is a no, this is different case, not this. I don't want to show you this one. This is after removal. This is a little bit later stage of this surgery. Wait, sorry for that. I will like to show the other one. You know, this is okay, this is, no, this is, sorry for this. This is just opening of the sphenoid sinus. This is also you will not like to see. No. Sorry, I think let me just prepare it. In the meantime, can you ask questions in the meantime whilst I am trying to get the right film?
Okay, let's see. Does anybody see any questions on the chat? Let me
Okay.
see.
Professor Go. So in your type 3 or type 4, how
Yeah.
often you can achieve the total resection of the adenoma?
See, it will depend on various things, as you can imagine, Ben. But your aim should be always to remove it totally and aggressively. But sometimes in the corners here and there, some tumor may be left behind. And if it is left behind, then there is no need to give radiation for that. There are, in general, more often than not, you have to remove it totally and radically.
Redap had a question.
Wait,
Okay, sorry.
let me get this video. I must, this is a unedited video. You must remember and don't, this is completely unedited. Okay, just watch this.
Unedited videos are the best ones.
Okay, I am removing, and it is done just yesterday or 2-3 days ago, this case, and it is on my screen, so I'm showing you. And this was a case of a large Cushing disease patient, okay? Cushing, as I mentioned to you, Cushing, that microadenoma should be removed radically in the form of a nodule. And you see, I am using a speculum, okay? This is not an endoscope. And this whole anterior wall of the sella has been exposed. You can see the entire sella is quite a large sella. And it is, and you must also see that I am using under very high magnification. So my magnification is very high. And you can see the whole, this is the entire thing is sella. And this is, now you can imagine my magnification which I'm using. Because, this is not a non-functioning tumor, and I want to remove this tumor as a nodule, as a complete tumor. So you please watch this. And this is completely unedited version. See, I am taking little careful dural incision because I want to remove it as a nodule. But if it is a tumor, which is a giant tumor, then I will take a deeper incision. The right will enter into the tumor because it is a Cushing. You see, the some tumor is coming out. See, I am separating with my knife. Normally, I will not do this because giant pituitary tumors, you don't have to remove it en masse. But Cushing disease patient, because this is a Cushing disease, I have to remove it like a nodule. If you don't remove Cushing disease as a nodule, then there is a possibility of leaving some tumor behind. You see, this was a largish Cushing, not very big, but the whole tumor is some tumor has erupted out, and I have removed the anterior wall of the sellar dura. Now I know from the scan that this entire thing is tumor. And I will like to remove this tumor in the form of a nodule. You see, I am increasing my magnification so much. And you see how close I am to the tumor. You see, now I am separating the nodule from the normal gland. In giant pituitary tumors, you don't want to do this kind of work. Maybe if I can show you one giant tumor also, I will like to show you. But just see this one, which is a Cushing disease. See, because it is large, I will have to identify as a nodule. I will try to separate. You see, some tumor has broken. You should not break tumor like in Cushing disease. You should not break the tumor too much. See, I'm trying to remove as a nodule because it is a large nodule. And as I have mentioned to you, wait, I'll take.
We kind of lost that end of the video.
Wait, I'll show you. Let me. In the meantime, Yuha, if somebody has to ask a question, I'll be happy to answer.
Okay. Yeah.
Professor Atul, thank you so much for the great presentation, as usual, and as expected.
Thank you.
Well, my questions, Professor, regarding the craniopharyngioma, I'd like to know your opinion for that stereotactic intracystic delivery of immunogenic or radioactive substance like interferon or like the bleomycin. So do you have any a clear-cut
I will talk on craniopharyngioma in one of my another lectures very soon. So you please hold on for my lecture on craniopharyngiomas. Okay? Because craniopharyngioma is one of the most, unbelievable tumors of the body. There are two tumors which nobody in the world has been able to understand. One is chordoma and one is craniopharyngioma. These tumors are histologically benign but behaviorally aggressive. Nobody knows which craniopharyngioma will recur. Nobody will know which chordoma will recur. If you see histologically, both these tumors are histologically benign tumors, but behaviorally, nobody has been able to ever understand these tumors. So that is the thing. You see this tumor I'm trying to remove as a nodule. You see the nodule? You see, I can break the tumor. In no time, I can break and remove the tumor. You see, it is a soft tumor. But if you can remove it as a nodule, it is best. I have broken the tumor here, but still I will try to remove it as a nodule, full en masse, because craniopharyngioma should be removed en masse. I have broken the tumor. As you can see, it is not good. Normally, I will not break the tumor, but this is a little biggish tumor, but you can still see the nodule. I must say, giant tumors are different. Cushing surgery is Cushing disease surgery. I know you are a little bit getting flustered with this blood, but I have told you that blood has to be enjoyed. Blood has to be handled. If bleeding is happening, then coagulation is not the answer. You have to handle the bleeding. And in pituitary tumors, you have to handle the bleeding in a very effective manner. And you will be surprised to know that if I have done 5,000 pituitary tumors, in 4,995 tumors, coagulation was not even used during the entire operation. You see the whole nodule I am removing? This is the technique of doing a, you see, I am not, if you remove, you see the whole nodule has come. Can you appreciate that?
Yes, yes.
You see the whole nodule has come. And you see the whole nodule has come. And if you can remove this, you can cure the person. In Cushing disease, the tumor has to be removed in the form of a nodule. That is the beauty. So that nodule has been removed. So you are any, by the time I get a giant pituitary tumors, you want me to ask any question?
John, do we have still time? We have been over 2 hours.
No, it can take as long as you want, whenever you
Yeah,
think.
we take this giant video.
Okay.
If somebody has one question, then we can take. But then
Sure,
we
sure.
Yeah. Okay.
Yeah, as long
Let
as
me
you
try.
want, as long as you want. No
Atul.
hurry. No hurry.
Just go on. Show the video on.
Yeah, just a minute.
Yeah.
Here, this is also completely an unedited version. And this also has been done maybe in this week or some other week. So don't get, now you see here, wait. Okay, just a minute, just a second, please. See, basically what we have to do is, can you see the screen,
Yeah.
Yuan?
Yes. Yes.
Yeah.
So here
Yes.
you see here, I am removing a largest tumor. I don't remember the size of this tumor, but you see I am breaking into the tumor now using suction and my biopsy forceps. And it is bleeding. The tumor is bleeding. So when one is doing giant tumors, you have to remove the lower part, the sellar part of the tumor first. And then you have to remove the sides of the tumor. You see lower part, I'm removing the sellar part of the tumor first using this kind of speculums, these kind of curettes. So John, don't record this because, you know, I don't want to let people know that I do these tumors. I want, like to show edited, nice, clean pictures. So don't, in any case,
Oh,
to show,
okay.
yeah, John.
I think those unedited videos are the best ones because they show the truth. The edited videos are lying so much, all incongruencies.
So you see this tumor, I am debulking using biopsy forceps and using curettes, and you see how I remove this tumor. And you will find that this large tumor, see, you will be surprised. You see the large size of the tumor I am removing? And I have no doubt that these tumors are best removed using microsurgery, microscope. With endoscope, is so much blood comes in your picture, you will get disturbed. See, I am trying to get the tumor down. See, the majority of these tumors are soft tumors. There is no need to coagulate this tumor. Just go on removing, remembering that the diaphragm is going to protect you. If you have that vision in your vision, you will be able to remove these tumors. And if also see this, how much is my magnification? My basic premise is that I know that the diaphragm is going to be protective. Can you see the tumor resection?
Yes.
Yeah,
Okay, now wait. Now I want to show you the further of this. Wait. Just a minute, just a minute.
Okay.
John, don't get restless during operation.
No, this is great.
In the operation, first thing is the surgeon should never get restless. And if I can see, John, you are getting restless.
No, I'm not getting restless. This is great. Keep going.
Okay. Now you can see the screen.
Yes.
yeah.
You see, I am removing the tumor. And I will like to show you the diaphragm if possible. I'm not sure in this case diaphragm is seen or not. But diaphragm will be seen in all cases, no question about that. And if you don't see the diaphragm, then you have not removed it completely. And if I'm showing you the basilar artery and see the endoscope, then of course, as I mentioned, that surgery is without any philosophy or without any concept. See, some CSF is coming in picture. And you can see the diaphragm shining underneath. Can you see that? You are?
Not yet. Not yet.
There
Can
is
you show
diaphragm
it?
here. Here, this is
Yeah,
diaphragm.
we can see. We can see.
Oh, okay, okay, okay. Yeah.
Yeah.
See, this tumor must be quite a big one. See, the whole diaphragm has to come into picture. Only then your resection is complete. Otherwise, it is not complete. And you see, I have not removed the planum sphenoidale or tuberculum sali. I have removed just the anterior wall of the sella. And that diaphragm, you see the diaphragm, how it is protecting you? See, you have to learn the art of breaking this tumor. The tumor is not broken by coagulation. You see the diaphragm now, more better?
Yeah, yeah. Yeah, yeah.
You see the diaphragm coming in picture, more better?
Yeah, yeah.
Learn the art of demolishing this tumor. Learn the art of using suction. Learn the art of breaking the tumor. Learn the art of operating in bloody field. Because many of the tumors in cavernous sinus, petroclival area, arteriovenous malformation, to operate, you have to operate in a bloody field. And you have to learn to operate in a bloody field. See, this tumor is still, I am trying to remove this tumor, preserving the diaphragm. And now I'm going quite in the rostral direction. You can appreciate that. Some now CSF is coming in picture. You see that? See, if CSF is coming in picture, it means you have to pack this area with fat. CSF is coming not because the tumor is going there. CSF is coming because you have made a rent in the diaphragm cell. Wait, I will show you the next part of this. Just in the meantime, in the meantime, if somebody has to ask last question, maybe.
Please go ahead. Is there any questions? Can you find John? The chat box.
John?
Sorry. It was about the transnasal approach. I'm trying to find it here. Hold on. Just give me a second.
Somebody was asking about why not to use the endoscope, but I think you explained that you cannot see so well.
You know,
when there's a
endoscope, I am
bleeding.
not saying don't use endoscope. I'm
Yeah, but,
saying, you know,
you told the difficulties.
you know, problem with, you know, I'm not saying you don't use endoscope, and also the problem is, please don't misunderstand me. I am saying endoscope is not necessary for pituitary tumors. I am saying endoscope may be necessary for maybe craniopharyngiomas, may be necessary for chordomas, may be necessary for other tumors, but not for pituitary tumors. Pituitary tumors are midline tumors. Pituitary tumor should be removed without, there is no need for endoscope in pituitary tumor surgery, because you know it, particularly for large tumors, if you use endoscope, there is no space for you. You see the whole diaphragm is in picture. Can you see the diaphragm now?
Yeah.
You see, I'm not sure if you can see, Jua, but I have just see, let us see how much I can show you in this. Because as you can imagine, I'm trying to remove now the basal part of the tumor. I should not leave that basal tumor. The whole tumor, the diaphragm is pulsating in my picture. If you realize that upper part, you see the diaphragm? The whole diaphragm is pulsating in my picture, and there is CSF coming and there is blood coming. But I must tell you, if blood is coming, there is no way you can stop this bleeding by any coagulation. The only way you have to coagulate there, you have to stop this bleeding is by continuing to remove the tumor and then pack this with gel foam and pack this with gel. Now you see, because there is CSF coming, I am packing this area with fat. I have not even tried to do any kind of coagulation or hemostasis, because this blood, this will never create any issue. You see, I have packed that area with fat, and then I will pack more fat. But also you must remember that fat packing should not be too much, and not fat packing is also a very precise surgical. So it is a good, you know, I'm showing you a little bit bloody and all those things, but you must remember packing of fat is also a very nice technique. You cannot overpack. If you overpack, you can have a problem. You see, I have packed the fat there now. Little bit I had moved here. You see, I'm holding that fat there, and then I'm putting more fat outside now. Now I'm not putting in the, you see, outside in the sphenoid sinus I'm putting. And there is no question of any worry about blood and all those things, no question. So that's the end of the story, my friends. And Yuha, so that is the situation.
Okay, thank you very much. Thank you, everybody. Thank you, Subin. Thank you, Takashi. Thank you, John. And thank you all those who were with us more 2.5 hours.
Bin, you have to make any comment, Bin?
Great. Actually, you presented with the concept of mother duro. Very impressive.
Thank you. Thank you.
That's great. That's going to be a classic from the king.
Yeah.
Okay, I'd like to thank Ben for translating into Chinese, and I'd like to thank Takashi for translating into Japanese. How'd we do this week, Ben?
I will, John, Yuha, I will communicate with you after 1 or 2 days, okay?
Okay, excellent.
Yeah, I think next week Dr. Lancino was speaking.
Okay, so I can present after he finishes.
So in 2 weeks.
Okay.
We will take the
Okay.
craniopharyngiomas. But Dr. Lancino will speak about the medical writing and publishing.
Okay, fine.
We'll get a good response. So,
That's
okay,
okay.
we'll see everyone next week. Thank you.
Thank
How many
you.
people
Bye-bye.
are there?
Thank you.
Bye-bye.
Bye-bye.
Subin?
Bye-bye. Bye-bye.
Bye-bye.
2,000 or something?